Hi, I'm Jennifer Roberts. In today's video, we're going to be talking about the patient-driven payment model and a few tips that can help your facility be successful. In the next few weeks and months, there will be more videos put out, so please make sure and hit that subscribe button so you can get on that list to see these videos in the future. So we're going to get started talking about the patient-driven payment model, and I think the first thing to notice is the name. So the patient-driven payment model is going to be driven by the patient, or what we usually call a resident. So typically when we think of long-term care, we think of residents coming into our facility and then staying in the facility. They're there for the continuum of their life. But with the patient-driven payment model and the new Medicare model, we're really looking at residents and patients coming into the facility and then getting them back out to their homes. So the patient-driven payment model really focuses on the patient and their clinical needs. One of the first things we notice with the patient-driven payment model is that the OT, ST, and PT are still receiving reimbursement for services needed. So if the resident requires 700 minutes of skilled therapy, we're going to provide that. But we're only going to receive one rate for reimbursement for PT services, a rate for OT, and a rate for ST. Those are not based on the number of minutes provided. There are other factors that contribute, but for now, we're just going to stay really light over this and just know that PT, OT, and ST are not reimbursed by minutes any longer. Then we have the RUGs 4 categories, the same as you have now. Now, many of you might not be familiar with RUGs 4. It is in the current Medicare model, but typically the rehabilitation RUG paid at a higher rate. So we didn't really see a lot of RUGs 4 payments, but now RUGs 4 will play a part. So if you are lacking education in that, we have some videos that you can see that can help bring you up to speed, but you'll really want to become familiar with that, RUGs 4. The non-therapy ancillary, this is going to be items such as the ICD-10 coding. We've got services that nursing already provides. Those services are wrapped up into this non-therapy ancillary. And then we have the non-case mix, the urban, the rural rates based on where your facility is located. So those are the areas that the patient-driven payment model looks at and are going to analyze and give you your Medicare Part A rate. So one of the things that I want to talk about here and ways to make your building successful is that initially when we were all told about the patient-driven payment model, we realized that we only have to do the 5-day. So for our Medicare residents right now, we do a 5-day, 14-day, 30, 60, 90. We're monitoring for COTs, those change of therapies. We have the start, the stop of therapy, numerous assessments. But with this, we're going to have the 5-day. So initially when this came out, everybody got very excited because, wow, only having to do the one assessment. But one of the things that we really weren't thinking about is that this 5-day is going to set the payment for the resident's entire Medicare Part A stay. Of course, we have an IPA assessment that we'll talk about in further videos, but really this 5-day is going to set your rate. So it's going to be very important that as soon as this resident is going to come into your facility, you're speaking with those hospital nurse liaisons, making sure we have all of the information from the hospital so we can determine the appropriate ICD-10 for these residents. So we have that on the 5-day that you're going to complete. The second area is section GG. So currently our Medicare rate is based on the 4 late loss ADLs, and we look at the rule of 3. So we look at all of the data collected over the assessment period, and we look for a rule of 3s, and then we code the most dependent level that occurs for that resident 3 times during your assessment window. That's how it currently is. But October 1st, what we're going to see is that now we're using section GG. And section GG wants the resident's usual status. This information will be collected on days 1 through 3. So section G, the way it currently is, we monitor the resident's late loss ADLs over a 7-day time period, or however long your assessment period is, and then we look for an occurrence of 3 items, and then we can code the most dependent level. But with section GG, we're going to be looking at days 1, 2, and 3 of the resident's stay to determine their GG functional status score, and that will help determine which category the residents will land into in the reimbursement system. So the same way section G does now, but GG is only days 1, 2, and 3. So when you're thinking about section GG, really we are looking at these Friday admissions that come in late. Day 1 of admission is considered day 1. So even if they come in late on a Friday night, that counts as day 1. So then we would have Saturday and then Sunday to make sure we have all of the data collected for section GG. And then we need collaboration from the disciplines. So everyone needs to talk about these scores, make sure it's the resident's usual, and then we'll have what we need for section GG. But just remember, it's days 1, 2, and 3 of the stay that we're collecting all of the data. So the next area is the primary diagnosis. So really looking at what is that diagnosis? Why is the resident in your building for a Medicare Part A stay? So this might be different than the primary diagnosis that the hospital had, because now maybe an issue's resolved, but now they require your services just to get a little stronger so they can go back home. So you are going to really need to become very savvy with the ICD-10 coding to ensure that we don't miss any of the primary diagnoses that impact one of these other categories. So my success tips for this brief overview and your plan for the next few weeks would be trying to determine who is going to be collecting the data for section GG days 1, 2, and 3. If you're an MDS coordinator, is that going to be you? Is that going to be an assistant, your CNAs? Who's going to be in the building determining what the usual performance is? And what tool are you going to use to capture this information? So really making sure that you have a plan for this. On the 5-day, since we're going to be completing that, and that's the one assessment that's going to be used for pretty much your reimbursement Med A rate throughout the stay, you're going to need to ensure you have all of the clinical documentation when that resident admits, or maybe even prior to admission, so you get the right primary diagnosis and also the comorbidities that go along with these, with each of the RUG categories. So making sure you're starting to develop your processes, even if that's just talking with the IDT, the DNS, talk as a team with therapy, with all of your staff to determine how are we going to be lining out these processes? Who's going to be gathering this information and collaborating if the IDT isn't there on a Sunday? So just making sure you're looking ahead at some of these changes that you'll want to get out in front of. Make sure and subscribe to this YouTube channel. As always, thanks for watching, and I hope you have an amazing day. And thanks for learning with Jen.